No one move.
You can start because I'm starving.
Okay.
Yes, sir.
Oh, we should start OTC.
Huh?
I thought I was the only one starving.
No, I'm starving.
Starving. I can't.
You didn't think.
You want to eat and come back?
No.
I'm gonna go study OTC.
Get done and start.
Let's put a time.
I need to study OTC.
No, let's do
It's
it.
a lot.
It's not gonna be long. So.
Well, I need her to be here because it's
Of course.
Sorry, I had to get my cupcake.
Okay, ready?
Yes, sir. Yes.
Alright. Number 3. Varenicline
Your favorite journal of all.
versus placebo. This is very similar to what article that we recently discussed?
The second one.
The second one where we did
Otitis.
augmentin versus placebo. So once again, it is not superiority, it is not equivalence, it's not non-inferiority,
It's a
it's a
comparison.
straight comparison between one and the other. Good? Okay, we conducted a randomized controlled trial to test the safety and efficacy of varenicline. So, efficacy, right, which the augmentin one have, but now we're adding safety. Right? Two things we're going to look at, safety and efficacy. We already discussed before about the per protocol should be the best thing.
That's your ideal.
That's your ideal. They're going to try to meet power, most likely use MITT as opposed to per protocol. Alright. In patients with cardiovascular disease, that's the specific thing of this study. Alright? So they're looking at people with cardiovascular disease, smoking cessation, this versus this, in terms of efficacy and safety. Good?
Yeah.
Alright. Study design, multi-center, randomized, double-blind, placebo-controlled trial of varenicline. Alright, many different places. Study population, 35 to 75, at least 10 or more cigarettes daily, and not try to quit in the last 3 months. Those are all the inclusion. Exclusion, pretty much anything else in terms of cardiovascular disease. If you've had something recent, they're not going to include you because your death or your something might affect the drug, might not have anything to do with the drug. It will actually be your cardiovascular disease.
Yeah, they exclude
So they're
one.
getting rid of all those people. Interventions, assessments, outcome.
What's really important about interventions? What does it tell you?
Randomized and stratifized, that's what you say?
And what is that called? Your
representative
your
of the
your
population?
randomization process, right? Because what do you know about the name of the study that you're doing here? What is the study design?
A randomized.
Randomized control trial?
So this is telling you
They were randomly assigned.
well,
You
the
like pick-
randomization process, right? Because it tells you everything. Why is that important?
It talks about random versus randomized.
Yeah, that's
What is the difference between random and randomized?
Random is like you pick 4
5.
people in a group, and randomized is you pick every 4th person
That comes in at a time.
coming
You
in.
have
And
a
what's the
structure.
benefit of randomized versus random? Yeah, you do.
Less bias.
there's more bias with
Control
randomly
bias.
with randomly.
There's less bias randomized than there is randomly choosing
Why?
someone.
Because
Give
it's
us
by
a
chance.
process.
Because you said you have
Your
a set
process, like I said, every 10th person, so you don't have any bias. You're not looking at them saying, oh, I want to put
It's
you.
being chosen by a protocol as opposed to a person.
right?
Right.
And then the big thing is, how does that end up setting up your two arms
It's not. It's like kind of.
Equal distribution
of,
of characteristics.
Of patients in placebo and in treatment group.
good. So it balances your study groups, right? If it's a randomization, if it's a good randomization process, then you're gonna balance for your known and your unknown characteristics better than if you just randomly pick people to put in there, because you may not get that systematic balance that you need in order to make sure that your two groups are balanced at what?
Yep.
Where they need to be balanced. At the end of the study,
The beginning.
Beginning.
and what's that called?
Base.
A priori.
Baseline.
Baseline.
Baseline characteristics.
Okay. Right?
Good.
Yep.
Outcome measures. Alright, so outcome measures, primary study endpoint. What do you get? Primary endpoint. Who can read it?
Oh.
Hmm? Oh,
What is
sorry.
The
You're
primary.
remembering, yeah, you're measuring the 4-week CAR
4-week CAR
during the last 4 weeks of the study treatment, which is from week 9 to 12.
during weeks 9 to 12, right?
Yeah.
So they looked at the patients for 12 weeks, and then the
No,
last,
they gave treatment for 12 weeks.
they gave treatment for 12 weeks. They're gonna measure in the last 4 weeks the abstinence rate of smoking. These people didn't smoke on weeks 9, 10, 11, and 12. And then later on, towards the end of the 52nd week, at the end of the year, they're gonna revisit these patients and see, are they still smoking, are they not smoking? Yes?
Yes.
So treatment is just all the way up to week 12, and later on they'll go on to week 52.
Okay.
Alright? That's the primary one.
The secondary is from 9 to 52.
Okay, so secondary,
The key secondary, because they
key
mentioned the
secondary. Alright, key secondary is CR from
whole 9.
weeks 9 to 52. Alright, and obviously this is related.
Yeah.
Alright, any other ones there?
Other secondary key endpoints were CAR for weeks 9 to 24 and 7-day point prevalence of tobacco abstinence at weeks 12, 24, and 52.
Okay, so these weeks and then different points to see if you're smoking or not.
Okay.
So these are all relevant to the main primary endpoint here, right?
Yes.
Okay. Statistical analysis. Alright, so 700 patients, right? What else does it say? 700 patients?
To provide 80. Oh, so that's to detect the secondary is 84,
Go to
and for
primary.
the primary is 99% power.
99% power.
They're very confident.
Well, they're really trying to find a difference. 99% power to detect what?
A group difference in primary endpoint. If the true 4-week AR for placebo,
True CAR 4-week
Varenicline conditions were 18 and 40%.
Okay, the true 4-week CAR. What else?
For placebo and Varenicline conditions were 18 and 40% respectively.
For placebo, 18%, and Varenicline 40, right?
Yes.
That almost sounds like 2-1. Remember when we were talking about that?
Okay, so what Dr. Garcia was saying, that this almost looks like a 2-to-1 Varenicline versus placebo difference. 40, 18, this were 20, it would be exactly 2-to-1.
But they're just like they're just throwing a number out there.
There's a method to what they're doing. You think they're just randomly picking a number, right? So what are they saying? What could you say with this? That alone, 40% and 18%. What kind of glorified statement could you say?
Varenicline is twice as likely
Twice as
versus
better.
placebo to have abstinence of smoking.
So what do you think they just randomly pick those numbers?
No, 2's a good number.
Alright.
Dr. Garcia, question, 99% power, how do you know if a study's overpowered?
What might they do, like what if you want to over-exaggerate something? What would you do? If you want to
Detect the smallest possible difference so that everything...
The beta like really minimize the beta.
Right. So, if I say that is a big truck, right? It's a big truck. What is a big truck?
Big compared to what?
Yeah.
Okay, so you gotta know it's compared to what, right? So, and then what do you think about? If I'm like, wow, that truck is huge, that's the biggest truck I've ever seen. Right? It's gonna be this enormous thing, right? So if you want to power something, can you power anything 100%?
No.
Okay? So if you're gonna try to get 99% power, that means you're gonna start with a group that's pretty big, right? So that you can, and the way you've got it designed and how you're measuring everything, because you wanna make sure that at the very end of this thing, you reach that power, right? Because how much, what is power? 1 minus what?
Beta.
And what is beta?
Error.
False negative.
20%.
Chances of failing.
False negative.
False. False
Okay.
negative.
So if beta is your false negative, right? And we have somebody who's spitting their water all over.
No, I said in the bottle. That's
Also,
it.
you mentioned in the class that the bigger the power, it's very difficult to detect the difference in that, right?
So if you want to detect a difference between a group of people, if the group is really small, are you going to detect a lot of difference?
Yes. The group is small.
Right? So if you have a huge group, are you going to detect a lot of difference, or is that going to sort of start to normalize things out?
It looks like normal.
Right? So if you have a really small group, it's going to be harder to match things up, right? Because they're so different and there's not very many of them, right? But when you have a large group of people, chances are you're going to have more things in common with those people, okay? So if you want to detect 99% power, right, which means 1 minus beta, and you don't want a whole lot of beta because your beta is your false negative, you're trying to reduce the amount of false negatives in this study. Okay?
Yes.
How often are things powered at 99%?
Very rare.
Okay? So it's going to be hard for them to do this, right?
Yes.
But if they do this, what's going to happen?
They're going to hit
Yes.
the goal.
Strong.
Exactly. So they're going for it here.
They're going all or nothing, pretty much.
Right? They're really going in because they're trying to reduce as much false negative as they possibly can. And they're looking at being able to detect a specific difference. Because if they are able to hit this power, then they can make a pretty strong statement. Okay? So, and this is their primary, right? And then they have a secondary. Okay, and in their secondary, it's the 84%, right?
Mm-hmm.
So then their beta, their false negative in there is what?
It's pretty big.
16.
16.
Okay, so 1 versus 16, where are they less likely to be willing to have false negatives?
Were they less likely?
Right.
Where do they not want a lot of false negatives to happen?
Primary.
Right? So their primary is very small because they want to be able to do what?
Should smaller primary?
Detect a difference of, right? That's what they want to do. They want to detect this difference.
Yes.
So if there's a bunch of false negatives in there, can they detect the difference?
No.
No. What do people who smoke say? You smoke?
I don't smoke.
I don't smoke. So
But
there's
they
a
do.
good chance of it being a lot of false negatives.
Negative.
So they have to control so that it's very, very minimal for them to be able to have a false negative. Okay? So they really got to control for that. Because there's going to be a lot of false negatives. Or there's a potential for that to be a false negative. Okay? Because when you're a smoker and you stop smoking today, if I test you for tobacco tomorrow, am I going to find some?
Yeah.
What about the day after that?
Still,
Maybe.
And what about the day after that? And the day after that?
eventually.
And the day after that? And the day after that? So even though you may have stopped smoking, I'm still going to detect tobacco in your system.
That's where the CO over 10 that they use to confirm, oh, you say you don't smoke, let me do this to make sure you're not lying to me.
Right?
Yes.
So if they, because that false negative, right, are you abstinent? Yes, I'm abstinent. You're going to hit a false negative because tobacco's still in your system. No, you're not abstinent. I can read tobacco. You're not abstinent. I can read tobacco. I haven't smoked in 3 days, man. I don't know what to tell you. So what do you got to do? You got to limit the amount of false negatives that you can accept, because you're going to have a lot of them, because tobacco doesn't go away the minute you stop smoking. So you have to, it's very strange that they've got 99% power here, but because they have to control so much for that negative, that false negative, because even though somebody stops smoking, they're still going to have tobacco in their system. So it's really hard to control for those false negatives. So that's why they're trying to power it this high to try to wipe some of that out. And if they're able to hit it, it's a pretty strong statement.
Yeah. Okay.
Alright, so next sentence. Efficacy outcomes were assessed with intention to treat analysis. We already discussed before that for these, ideally you would want per protocol. We just discussed about the power and the patience, right? And they're using intention to treat to make sure, most likely, that they get their 99% power so that they can go for the gold and make the strong statement Dr.
Yeah.
Lucia was talking about. Does this make sense to you guys?
Yep.
Why they're using this and not anything else? Yes? Alright. Alright, 2 or 3 sentences down it says, for calculating...
Hold on.
Sorry.
Are you confused?
No.
You
I'm just
sure?
hungry.
Okay.
2 or 3 sentences down it says, for calculating CARs, a participant who missed a visit but had a CO validated report of continuous abstinence at the next visit at which smoking status was available was considered a non-smoker. Does this bring any bells into your head?
Looks like
Last
I don't see it.
observation.
Last observation carry forward, exactly. So if you're at week 2 and you didn't smoke, you didn't go to week 4, and then at week 6 you come back and they test you, you're still not a smoker, they take your week 2 data and bring it up to week 6. Yes? Alright. Primary and secondary endpoints were analyzed with a logistic regression model, included treatment group and study site. Hypothesis testing was performed with a likelihood chi-squared statistic. So, do these tests match the data? What do you guys think?
Well, if
What's
you're-
your data?
You did it if you're a smoker or not. If you're still smoking or not.
Chi-square is what?
Non-parametric
Non-parametric.
test.
And what are they measuring?
They're measuring to see your CR values.
They're measuring your CAR values, or they're asking you if
The
Asking
you're-
you-
CR, it's a yes
asking-
or a no.
Asking if
Right.
you're smoking or not, yes or no.
Yes or no. So that's nominal. Yes or no. So they're using chi-squared, so that makes sense.
Yeah.
Okay.
Alright? So, nominal. Chi-squared. Check. We're good?
Yeah.
Alright. Anything else before I move on to results that you guys would like to look at? Alright, results. Flow diagram. Who wants to talk about the flow diagram? Anybody?
They said that safety outcomes were assessed among participants who took at least one dose of the drug.
Okay.
So that's significant too. I mean, they're just saying they took one dose and that they're still considering them to detect if it's safe or not.
Okay, I'm going to erase this and actually draw the flow diagram a little bit, because if you don't see it, it's going to be very hard to...
No, you,
Alright, you have your 7-11 people here, right?
yeah.
Now.
7:14.
7?
14.
14. my
You're just
bad.
thirsty.
Yes, 7:14. Okay, so in this study, they're looking at efficacy and safety. So there's 4 boxes, right? They're looking at, this is your placebo people, and this is your Varenicline people, right? You have another one here, and then you have the bottom ones here. Now, you have 355, 353 in efficacy, safety, analysis, right?
Mhm.
So this number is what they're analyzing, right?
Yeah.
All right. 359,
350.
350, efficacy, safety, same thing, analysis.
Mm-hmm.
How much do you have? Okay, so they were divided into what? 350?
355, And
355 are in this group.
but only
3
353 got the drug.
53 received,
The drugs.
right?
Yeah.
So this equals
Or MIT.
MITT, right?
And why?
They
Received.
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 They
Magic
got
word.
something.
Whenever they get something, that is your modification. Let's do this over here now. 359, right? This is your intention to treat. 359, the 355 here is your intention to treat. And then 350 received, right? So this is your MITT. Yes? Now, you have these boxes and you have to make sense of the numbers. So let's just think of this part as the safety, this part as the efficacy. Now what do you have? 64, discontinued, whatever, 286. 70, 289. Okay, 70 discontinued here, DC, discontinued. 286 completed. Another magic word in the world of BioLit. What does this magic word tell us?
Protocol.
Per protocol. Now we're talking. Okay, so per protocol. Let's go over here. 293 completed per protocol. 60 left for whatever reason. 53, 302. Alright. So safety and efficacy in the treatment, safety and efficacy in the placebo. We're good so far.
Yeah.
Analysis. Down here. Where do these numbers match up to these?
Up there.
Good job. Anything specific about up there?
It's our MITT number.
For which one?
For 353 is our MITT.
And what is 353 is what type of analysis?
Safety analysis.
And what's the 355?
Our efficacy.
And
That's
what is
our
that?
intention to treat.
Is that what they told you?
No.
Is that what they told you in the manuscript? What they were going to be doing, the efficacy and safety?
Yeah. So we're good.
I have a question. How do you determine the safety and efficacy when you put them here in the second?
Great question. 289 box 70. What does that add up to? The answer is 359.
359.
All right.
Okay.
Hence, efficacy.
Okay.
Efficacy.
Okay.
I told you this beforehand, but that's really how you determine it. Right?
Okay.
286 plus 64 in circles instead of boxes equals,
Yeah, okay.
yes?
Yes.
Same thing up here. If you do the math, 353, 355. We're good?
Yes.
So what are they using overall here? Modified, right?
Modified.
All right. Any questions? So,
So they use modified to
Dr. I
reach
see a
power?
question. The safety part is modified, but the efficacy is intention to treat. Is that like normal to do? Have
What do
two
you
different
think?
ones? That doesn't sound normal to have one thing as an intention and then another as a modifier. Why don't they just use the same for all of them?
Because they're taking into account what with efficacy?
People that drop
Because
off.
where's efficacy? Is that,
Took the drug.
what's the difference between efficacy and effectiveness?
Efficacy is whoever completed the trial, right? That's why even I'm stuck. Like, but effectiveness
Your work
is like
side.
the real world.
Okay, so which of these things is most like the real world?
ITT.
Intention.
So
Efficacy
that-
most likely is per protocol, really, but the next step would be.
So if efficacy, if the best way to determine if a drug works is to actually take the drug, like you're supposed to, right? That would be your per protocol.
Yeah.
But we know, just smokers, are they successful at quitting?
No.
Okay, so there's a lot of treatment failure,
Yeah.
which is why we tried to rule out a bunch of things, empower it certain ways. If we're looking at the efficacy, right, because we're looking at safety and efficacy, that's in the study, right? So if we're really looking at how well it works and we're looking at per protocol, that's not normal for what you're going to see out in the real world. But what do you really see out in the real world?
Effectiveness.
Effectiveness, treatment failures, problems.
Intention.
So if you go to your intention to treat group, you're going to get a little bit closer to what you might actually see out there versus what's super controlled, because look at your per protocol numbers.
It's very low.
They're a lot lower,
Not powered
right?
to meet your.
So you are taking in some failures when you analyze how effective it is by using the intention to treat, right? You're taking in more failures that way than per protocol. So you're sort of saying, you know, in the real world it might actually look like this. So
Someone says it's better.
well, it's a good design in terms of how it might look out in the real world, but you still don't really know how well it works if you are only, versus if you were only looking at those per protocol people.
Because they didn't take it, so you don't know.
Well, they may have taken it, they may not have taken it, right?
To make things simple, they should have just mentioned effectiveness here.
Is that their job, or is that your job
our
as a
job.
future pharmacist? Okay, just checking. Right?
Any questions on the flow diagram, safety, efficacy?
And I think I asked this already, but we used the safety to say we met power, or I mean,
How do you meet power?
you made it to 714,
Well, 700 was what you needed for the
700, yeah.
99% power, right?
but we can use either one.
Well, look what, that's the thing we're saying here.
But
Efficacy.
power to what? Power is not just it. It's power, and then to what?
So what was it?
To detect a difference.
So you're detecting a clinical.
A
Clinical
true
safety.
4-week CAR difference in Varenicline versus placebo.
So, they both, in this case, are going to meet the power of 700, right? So you have your three, in terms of efficacy, right? If you add up, where are they? The efficacy, 359, 355, that's going to give you 714, intention to treat. If you add up 350 and 353, that's 703,
Still
right?
power.
Modified intention to treat, you still have your 99% power.
So they both meet power.
Yes.
So okay.
Right. If they were to use per protocol, right, they would not meet
That would
power.
not meet power.
Right, because the, what is it, 289 plus a 302 does not give you 700. Alright?
Okay.
Next. Question. When in the results the authors say the superiority of varenicline over placebo, is that kind of like biased?
Yeah.
Is this a superiority?
No,
Trial?
it is not. Bias.
Next. Again, the superiority of varenicline. Alright, table 1. Characteristics. Does it say anywhere about them being the same? Did you guys
Yeah.
Baseline characteristics of the randomized participants were comparable between treatment groups. End of the results paragraph. Right before efficacy.
Yeah, I missed that.
Now, hold on. Table 1.
What was that?
Noticing...
He was talking about the baseline because he was asking to check this over here.
Right. Yeah.
Because in the chart it doesn't tell you. It doesn't give you a p-value. So they're just telling you.
Oh, okay.
Question. Table 1. They're doing the different demographics and all that. Look at the gender. What do you guys notice?
Just
It's
male.
mostly female.
It says male, right?
Mhm.
And it says a percent.
Mm-hmm.
What are those percents? Read them out.
What do you mean?
In table 1, gender, male. It says a number.
75% was male.
75% of the people are male. Do you think that's representative?
No, because women smoke too.
Exactly. And there's more women in this world than there are men.
Yeah, but then men smoke more.
I don't know. Is it?
I don't know, I'm just saying.
What do you guys think?
Also on the side they say female and non-white participant samples were too small to permit significance testing.
So they noted it
I
that it
don't
was
know what
limited
it's-
that they did it. They didn't just they acknowledged it.
Okay. So that's a limitation, right?
Yeah.
Anything else you want to look at here?
I have just a quick question. So gender here, male or female, it's nominal, right?
Yes.
But
Yeah.
percentage, does it like emphasize on anything else? No, right? It's just, no, it's a dumb question.
Age?
Percentage.
Percentage? How could you
Yeah.
figure out how many males are in there?
You need a number.
Percentage.
So you have an N,
Yeah,
and you have a percent,
yeah.
and that would be male, and then what would be female?
The other, okay. Okay. Just got lost.
That's okay.
Anything you want to discuss in terms of efficacy or safety?
We can talk about the adverse effects that they didn't correctly report them.
Yeah.
Okay, let's talk about adverse effects that were not correctly reported. So talk to me about it.
It says table 2 on
Table two.
page. First, it mentions it in the safety measures.
Okay.
It says that other than sleep disorders reported by patients, psychiatric adverse effects are uncommon and did not differ significantly between groups. But if you look in the table, it was a significant difference.
The sleep
between-
disorders, right?
Yeah, sleep disorders was significantly different. Do you see that?
I
Yeah.
see the table and the sleep disorders that you're telling me.
Yeah, the confidence interval is like 7.1
7.1 to 17.7.
And 78.
Percent difference between groups is 12.4. So
So it's significant. They like brushed it
how
off.
do you determine that that's significant?
Because of the confidence interval.
Confidence interval. It's way past 0.
Okay, so
So
here
is-
showing significant, and in the article they're saying it's not.
Yes, they said it's not differ significantly between groups.
So if 0 is included, it is significant, or it's not.
If it includes 0, then it's not
It is
significant.
not.
What does it include? Does it include 0?
No.
This has no
Include one?
0. No.
No.
No, 7.1 to
It is
17.7.
But this confidence interval is because it's difference between groups. It's 0. If it has 0, then it's not significant. Not 1.
This is what?
It's from base.
It's from baseline?
This one is this one is significant because there's no 1 and no 0, and the number is like way above, like 7.1 to 17. So
They're
there is a
comparing
difference.
two groups.
Yeah.
It's a reduction.
So sleep disorders with Varenicline group is very high than the placebo group. That's what they're trying to say here. Is that right?
Read the sentence. Starts with table 2. Right?
Did I just read that one?
Read it again.
Table 2 also displays adverse events that were classified as psychiatric disorders, other than sleep disorders reported by 22.
Okay, slow down. There was a comma in there.
Reported.
Start with the beginning of the sentence.
Other than sleep.
Other than
So sleep disorders.
Other than
or-
sleep disorders,
got it. Okay.
AEs were uncommon and did not differ significantly.
Okay, my question. Look at the Kaplan-Meier curve, figure 3. I'm gonna erase all this, yes? Okay. Kaplan-Meier curve is a
Time to event.
time to event measured by
Hazard.
hazard ratio. Why are they talking to you in odds ratios here? Does everybody see that? Figure 3 is telling you week 12 odds ratio, blah 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 blah.
Where are you?
Figure 3 Kaplan-Meier curve,
Kaplan-Meier.
Oh,
right in the discussion
Yeah.
section? Okay. So if you look at figure 3 down there,
Mhm.
it's telling you week 12 odds ratio, blah blah blah. Week 24 odds ratio, blah blah blah. Week 52 odds ratio. Why are they giving you odds ratios on a Kaplan-Meier curve?
Probably to make it look better. I don't know.
Yes. Dr. Garcia?
Oh, are you
Is
asking
that
me
a,
now?
is that
I
a
was-
deficiency?
Well,
Shouldn't they be using a hazard ratio for that?
they are
No,
measuring the what out of what?
The what out of what?
Are they measuring abstinence,
Yeah.
or are they measuring abstinence in one group out of another group?
They're comparing absence in two groups. Against the two
It
groups.
says abstinence point prevalence percentage.
So what is a point prevalence?
At one single point in time?
So over a certain amount of time.
Which one is it?
After 7 days.
Point prevalence, week 12, week 24, week 52. Those are the points they're looking at to see the abstinence rate in each group at those points. Is that correct?
In the figure 3,
Mm-hmm.
right, it's a point prevalence of 7 days. So every 7 days is 1 week. Right? So at the bottom, you have from week 4, week 8, week 12, right? Then week 16, week 20, week 24, week 28. So each of those points represents what? CO validated abstinence from any tobacco product in the past 7 days. Okay? So in a hazard, are we looking at an interval of time, or are we actually looking at a point?
We're looking at the rate of the event.
So here, it happens here, it happens here, it happens here, right? And here, we're looking at, because we're saying in the past 7 days, have you been abstinent, right? So each time you're in, like in a typical hazard ratio, right? You usually have the Cox proportion regression, right? So all of those points are regressed back to the mean, so you don't have 1,000 lines going, you just have 1 point,
Yeah.
right? Well, here, that 1 point is actually representative of a 7-day
Cumulative.
accumulation, right?
Yeah.
And did they do regression here?
They did.
Did they tell you they were taking these and linearly regressing them back? Or were they comparing the two over time?
I would go comparing to.
Comparing over time.
So the only way they can show you a comparison of those two over time is to show you what? Is it to show you a hazard, or is it to show you a comparison?
Comparison.
Right?
So that's why they use an odds ratio?
Because in here, they're using odds. It's not the best, because over time, you see a difference, but because of how they set up their study design, right, they have it in blocks of time. But how they're measuring abstinence, it doesn't matter if on that particular day, they're abstinent. Why?
Depends on 7 days.
Because it's a 7-day point prevalence, and even though they're abstinent, what can you still read?
Tobacco. So that's why they need 7 days because of the.
Because they have to have that, they have to be able to do that. And so they can't necessarily regress to the mean for each one of those, because it's not going back to the beginning, it's going back to the 7 days, right? So in your hazard ratio, it's a regression.
It's a regression, yeah. So
All the way back to the mean, right?
Okay.
You regress back,
So using a hazard ratio in this Kaplan-Meier would not be most appropriate, so therefore they are doing odds
well,
ratio.
they're doing an odds, but they're trying to show you something over time.
Okay.
So that's why they do it.
Is there any other way to do that besides an odds ratio?
Yes, but it may not give you what you want to see. It may not give you something that's very pretty to see this, right?
Okay. Any other questions we have?
I have a question, which I already asked you like 2 weeks ago. So when we read the PowerPoint, we want to focus on whatever we can apply in the journal club, not outside.
What do you mean? Give me an example.
Do you have your PowerPoints? Like the clinical guideline PowerPoint. Like that we don't really.
What do you need to know about clinical guidelines?
The best is A form or whatever that thing. A.
How do you know
Grade
what you
A.
should look at in different lectures?
Objectives.
What? Oh. But you want us to do that then? To look at every PowerPoint and study it as...
Did I tell you to look at every single PowerPoint and study every single slide?
No.
Mm-mm.
The last lecture,
Literature part 1 and 2.
she had the notes. I mean, if you find the last lecture that she did.
Which one? The
The
recitation?
very last, no,
Oh, just
lecture
the
in
last.
class. Pretty much tell you what
She
she's
went
doing.
over all the different graphs.
In a nutshell, what's your clinical practice guidelines?
It's a way to make
The best
make
clinical evidence available to
make
treat a
decisions for
specific
patients.
disease in a patient.
So if you know what they are, you know what they're used for, right? If the objectives out of that lecture,
Mm-hmm.
am I gonna ask you to point out like all the different components of a clinical guideline? Cause is there just one?
No.
How many clinical practice guidelines are there?
God knows how many.
Thousands,
AIDS alone.
right? So if I was gonna give you a clinical practice guideline, I'd have to give you a what? A whole set of guidelines.
Negative.
How long is that gonna take you to read through a whole set of guidelines? Would that be something I would throw on your exam?
No.
No.
So what kind of things do you think you need to know about clinical practice guidelines?
Where to go and look for it? Where is it available for free?
The general concepts.
The grading maybe.
So you-
evidence to
okay.
get onto again?
Yeah, the grading. So we do have to, because that we don't apply on an article. But for you, for your part, you still want us to.
Is the
Read those
most important part of this class being able to apply the clinical practice guidelines?
No, to me, it's doing this.
Right. So when you think about what we talked about with the clinical practice guidelines, what were things that we talked about?
I just remember the grading.
Okay, so that's a component of it. So when I talked with you a couple weeks ago, and you said, I don't know what I'm supposed to study, what did I tell you? How can you sort of identify like the main important parts of a lecture?
Objective.
Start with your objectives, look at the slide, and if you can explain what's on there, then you already know it, right?
Right.
Is it like gonna be a 50-50?
No.
And Dr. Harrington's lecture, the first half is not on the test, right? Because it's not
Yeah,
integrity.
Well, the information is there,
Yeah.
right? It's in her slides, it's in her stuff. The first hour or whatever didn't record, so there's only like 34 minutes left.
Uh-huh.
But the things that she focused on in her objectives, the main parts, right? But no weird random details, the main parts. Same with Dr. Kim, Wellborn Kim.
She's a lot of.
Okay. So the whole PowerPoint is fair game then, not just what's on integrity.
Yes, and of course I went to the PowerPoint and thought, what one slide are they not going to pay attention
No,
to? And I'm going
because-
to pick that because that's actually something they should learn.
Remember that she said at the beginning, she was like, "Oh, this is something you should really, really focus on my test." And then I didn't write it down. So I don't know what it was.
I wasn't there. I don't know. Guess you have 237
And she emphasized
questions
that.
you can ask.
Huh?
She asked to focus on mu because that's her practice. So that's her practice.
Medical use
setting, so-
evaluation, which is
What
in the
was it?
hospitals. As
Okay, you
Medical
guys
use.
know. So that's what she said?
It's very general. There is no like.
I don't know. I just
technical
remember her
part, like,
saying
very
very.
simple. Yeah, she said that is her focus of practice, and probably she's going to ask more questions.
Are we
like that.
done?
So,
So her focus is on medical.
MUE, I don't know what it's
MUE. Oh, okay.
Okay, let me know if it works.
Does
'cause
she
I'm
didn't
not
say
gonna do it
anything?
again 3 times.
The whole thing is
That's
about
it.
MUE.
Somalia, save
You don't
this.
have to know how to do it.
That's it. No more questions.
Bye.
Bye.
Thank you so much, Dr. Garcia.